Hi everyone, I want to talk about BPH. BPH, benign prostatic hyperplasia. Benign prostatic hyperplasia is a non-cancerous enlargement of the prostate gland. So it's just an excessive growth of cells around the prostatic urethra. So it's not cancerous. That's why it's called benign. But that compresses the urethra and prevents normal urine flow. That would lead to urinary retention, discomfort, and other problems that would be associated with urinary retention. It is a benign condition from the name. Why? Because it is not a prostatic cancer. So my grandfather could take a deep sigh of relief. The clinical features are in two groups. That's what we call irritative symptoms and obstructive symptoms. As you could see on your screen, the irritative symptoms will involve frequency, that is going to the washroom or toilet or joint, as you may choose depending on where you are on the surface of the earth, more frequently, and have the urgent need, the urge, the drive to go there, very quickly. Pain at night, nocturia, and could be painful sometimes, particularly associated with urinary tract infection. The obstructive symptoms will involve, because I've said just a minute ago that it's going to form around the prostatic urethra, so it's going to compress the urethra, so it's going to obstruct the free flow of urine out of the bladder. Then the stream of the urine that will be produced very weak. The man will have to be straining, and there will be incomplete emptying. The size of the prostate doesn't determine the level of the symptoms. The risk factors there are increased age. The older you become, the more the likelihood if you're a male gender, and those that have increased weight, particularly around the abdominal region or truncal obesity, stand higher risk. Sedentary lifestyle, of course, that will give, encouragement to truncal obesity, right? So they are both interconnected. So truncal obesity, sedentary lifestyle, and you are a male and you're getting older, then you are inviting benign prostatic hypertrophy. What are the possible investigations here? The first is physical examination, which is digital rectal examination. Okay, then you can do urinalysis, know the level of blood urea nitrogen, creatinine, urine microscopy culture sensitivity, because with the retention of urine, you are likely going to have urinary tract infection the more. You have your ultrasound done to see what's happening to the kidney, urethra, and the bladder. Prostatic specific antigen to rule out prostatic carcinoma. There are a lot of controversy about that, but I'm not going to go to that right now. When I'm presenting on prostate cancer, I'll talk more about prostatic specific antigen and the associated controversy. Then we're going to clear the air of that. Uroflowmetry is going to be useful here, and that will help to measure the flow rate on how much urine could be retained by the bladder and how much is flowing through the urethra. Cystoscopy to look at the bladder itself and whatever problem is happening around the bladder neck that is causing the obstruction. If enlargement is big, with the aid of ultrasound, you can do the biopsy. If PSA is elevated, that is prostatic specific antigen is elevated, and you are worried and have the ultrasound guided biopsy of the prostate. Some will even do pelvic region X-ray. Depends on the protocol at the center. So with the digital rectal examination, I've decided to bring it out separately so that I'll be able to lay more emphasis on that. Because when you do the digital rectal examination, that might be the deciding factor on what you do next. So if it is smooth, rubbery, enlarged, and symmetrical, then you don't need to bother yourself. This is not prostatic carcinoma. It is truly benign prostatic hyperplasia. Some will call it benign prostatic hypertrophy. So digital rectal examination done on the couch there is a big factor in determining what is next to be done. Okay, as per treatment, the first thing to do in acute case involving the urinary retention and you are sure of what you are dealing with is pass Foley catheter. When you pass Foley catheter, that will drain the content of the bladder through urethra. I will not go for suprapubic tap right now. Through the urethra, just drain. And that's going to happen in the office, right? In the clinic there, office procedure. There was a case of an elderly man who came in with his children. The children are also big people and not tiny people. I mean, they were all so anxious because that was the first time, that was the first, experience that the man would present with. Never been diagnosed with BPH before. So when I passed the Foley catheter and the content got drained, you know what followed? The man yelled, "Oh my goodness, I need it now." So that is to tell you how much they could become relieved by doing this small single procedure. Just passing the Foley catheter and the man will be happy with you. The treatment here will start by watchful and waiting, because it's not everybody that will need all the stress of medication, surgery, the possible side effects and complications that will follow. So watchful and waiting will be helpful in about 50% of affected men, because about 50% of them can actually improve on their own. They will improve spontaneously. Then you can assist this grandpa by having a planned voiding time. Then decrease the coffee and the pop, particularly at the evening time, so that they can have a good sleep. Adrenergic antagonists, I'll talk more about them very soon, but just to let you know that they are useful because they decrease the stromal smooth muscle tone, so thereby relaxing the tone and allowing more urine to flow. While 5-alpha reductase inhibitors will block the conversion of testosterone to dihydrotestosterone, and in that case will decrease the prostatic size. At least if it is not going to go down so much, it will not be increasing in size with the help of 5-alpha reductase inhibitors. There's a new drug out now, but I don't know how new it is anymore. That is beta-3 agonist. Mirabegron is out to help as well. Anti-cholinergic agents. It is controversial. So many centers are comfortable with it, but in the next slide, I'm going to explain more about that. Some will do transurethral resection of the prostate and many more interventions. Let's go. Anti-cholinergics and benign prostatic hyperplasia or benign prostatic hypertrophy. Many won't give anticholinergics, and do you want to blame them? No. Why that? because they have urinary retention as possible side effect. Okay, that is reasonable. When the enlarged prostate is already causing urinary retention, how do you want to give a medication that wasn't there? But American Urological Association recommended anticholinergics if there are following. One, if there are irritative symptoms, anticholinergic will be useful to treat that. And if you have your post-void residual volume and it is not high, it is very low, you can still go ahead, which means they know that the level of retention that will be caused by anticholinergics will not be detrimental to the patient. And you don't give these anticholinergics if your post-void residual volume is greater than 200 mils or more. Some will say 250, some will say 300. Be comfortable if it is not greater than 200 mils, courtesy of American Urological Association. You can have laser ablation, transurethral incision of the prostate if it's less than 30 grams, open prostatectomy, microwave therapy, transurethral needle ablation, and some will give prostatic stent. There are medications that you can lay your hands on and give these people to help them. If you combine tamsulosin and dutasteride, you are likely going to get good synergistic effects. Good synergistic effects. You can also go ahead with doxazosin, terazosin, afuzosine, and silodosin. They are all alpha antagonists. Finasteride and dutasteride, that is 5-alpha reductase inhibitors, are very, very good here. Please kindly avoid, if it is possible, avoid antidepressants. But I've just said if it is possible, because if my grandpa is depressed and having benign prostatic hypertrophy or hyperplasia, how am I going to avoid antidepressant here? So if it's possible, avoid antidepressant, avoid cold meds that you get over the counter, particularly all the congestants containing pseudoephedrine. Diuretics, because the urine produced by the kidneys won't be able to get out. And the work of diuretics, particularly high-xylene diuretics, is to flush out fluid from the body. But where is the exit? Avoid antihistamines the way you can. Most time, surgery is not what will be prescribed first, but there will be need for surgery under certain situations. One, if there is repeated urinary tract infections in this man, he's been having urinary tract infection repeatedly because of the retention of the urine, then you call for surgery, because retention is what is giving room for the UTI. If you have tried your 5-alpha reductase inhibitors and alpha antagonists and they failed, then you try surgery. If you do your cystoscopy or ultrasound or anything and you pick bladder stones, then surgery. Or renal failure is setting in here, then no time to waste anymore. What are the possible complications? Hydronephrosis, blood in urine, bladder stone from the stasis, renal failure. Of course, retention is obvious, urinary tract infection, and overflow incontinence. In conclusion, there will be a separate presentation on prostatic cancer, and that will not be long from now. be on the lookout. Kindly subscribe to my channel so that you can have these presentations immediately they are published. Thank you.